Okay, welcome back to part two of our peripheral nerve block presentation. We again welcome all of our folks from Cameroon. I hope you have enjoyed part one. So let's get started with part two. First, we're going to discuss the various techniques to, finding the nerve of interest or plexus of interest. And basically, we started off with the paresthesia technique. So you may palpate an anatomical bony prominence or pulse, and then maybe seek paresthesia from that nerve when your needle basically comes in contact with it. And then we progress to nerve stimulation technique, where roughly the same type beginning, but instead of eliciting paresthesia, we were looking for nerve stimulation, and you would elicit a motor response that was expected for the desired target nerve. And then we progress to ultrasound. And certainly ultrasound has some advantages as far as, mainly avoiding vascular structures and watching for extravasation of the local anesthetic, or expansion of the field in the perineural area with local anesthetic to help us identify that we're not injecting intravascularly. There's some issues with that a little bit with vein compression if we're pushing too hard with the probe, but nonetheless, it does help us also surround the nerve with local anesthetic in a much more accurate manner. And but again, it can be also confusing as well as some of the anatomical variations with patients. And so we'll go over the various techniques, mostly concentrating on nerve stimulation and ultrasound. So first with ultrasound, some basic ultrasound review. If something is echogenic, it means it's capable of producing echoes. And this correlates with terms like hyperechoic, hypoechoic, and anechoic. And that's just referring to the quality of the echoes produced. So kind of just think about when a sound travels and hits something really hard and it bounces back very strongly, that's going to be hyperechoic. The ultrasound that we're using with our patients, we can kind of think of hitting like a bone or something. It's obviously very dense, and it's going to return the echo sound waves back to the probe in a strong manner. And basically hypoechoic is kind of thinking maybe like a muscle type structure that has some fluid in it, some striations, and it's going to absorb some of that, those sound waves, and it's going to return fewer and weaker echoes to the tissue, from the tissues. And anechoic refers to a structure that has no echoes. And we think of like fluid filled spaces for that, something like a cyst or a blood vessel. It's going to absorb the sound waves and not going to return any echoes, and that would be considered anechoic. So hyperechoic is going to send back, it's sending out sound waves, echoes back very strongly, multiple waves coming back, and so it's going to be very bright in color. Hypoechoic is going to absorb some of those, send back fewer and weaker echoes, and that's going to return the image of something a little darker. Anechoic can be really dark or black. That's where it returns no echoes. And that's we think of that as a fluid filled space, is a good example of that. Frequency. Frequency is the number of times in a given interval that a particular action occurs. And so as we increase the frequency, we're sending more and more sound waves. And that's going to be useful for something that's more superficial, 1 to 3 centimeters in depth. Again, that's the target zone, if you will. And that's going to allow us to have a very high resolution, very robust image. If a high frequency is used for structures that are deep, let's say 5 to 6 centimeters or more, 10 centimeters, like with certain abdominal or chest ultrasounds, we would lose resolution and you'd have a lot of scatter, and it would be a very poor quality ultrasound. So we do want to be mindful if something is a deeper structure, we want to lower the frequency. Kind of think about it has time to get down to that depth. and return in order to create a good image. Versus if it's high frequency, and it's a shallow or superficial type structure you're looking for, it's okay to send a whole bunch of sound waves because it's going to return relatively fast, and you would have a very clear, high resolution type image. Gain regulates the amplification or the brightness of returning echoes. And basically that's to compensate for the loss of transmitted sound caused by absorption or reflection. And if you go in the sonographer world, ultrasound technicians and radiology type folks, they really kind of have their gain turned down a little bit. So it'll be a darker image. And I'm kind of in that camp. Not that I, previously was a sonographer prior to coming to being a nurse anesthetist, but the idea is I like to really enhance the surrounding anatomical features, and really helps me fill in that anatomical puzzle. Versus as you increase the gain, you kind of brighten everything out, and it's really going to start kind of distorting the image a little bit. So it's a fine balance between increasing the gain to have amplification, where you can see your needle example, for example, better, but you're going to lose some of the details of the anatomy differences and tissue planes as we go too much with that. So be cautious with gain. It can kind of distort your image a little bit. Time gain compensation or depth gain compensation, that compensates for the loss or attenuation of the sound beam as it passes through tissues. And that's just trying to enhance that image, especially when we're looking for something a little bit deeper type structures. So this is a good example of a high quality ultrasound image that allows us to see good striations, good fascial planes, and also allow for us to be able to see our needle as well. So it's a bit of a best case scenario. And so again, we can see our needle here. I'm going to just kind of annotate that for us there. We can see that. And then we can see the tip right in this area. But we also can see this really bright line right here, right? And that's the bone. And so in this scenario, this is a rectus spinae plane block. That's the transverse process. It's nice and boxed in. It's not round where it's quite the rib. And we notice this dark area behind the hyperechoic area right here. That dark area is, remember, this is an ultrasound. It's not an X-ray. You can't see past that. So basically, it hit that hard structure, bone, the transverse process, and came back with a very strong signal. And that's why it's hyperechoic. But there's nothing, no image here to tell us what's in this area. We know that that is the transverse process, and that's the bone, but it could be a little bit misleading if you're wondering, like, is that a blood vessel maybe over here? You're not going to be able to see that because it's being distorted by that hyperechoic or very dense bone. Versus with the fascial plane out in here, we can see past it. While it is hyperechoic, all of these, you see the different muscle groups. And so as we're getting to this area, we can still see past it. And that's when we know that's more like a fascial plane versus something like this would be bone, because we don't see anything after that. And so it's not really, this wouldn't be a fluid compartment. This would just be as a result of the sound waves and coming in contact with a bony structure. We're really not going to discuss this block in particular with this phase of our project, but I thought it was a good image to really bring out the various striations, fascial planes, and really be able to discern the difference between contact with a bone creating hyperechoic echoes versus pretty hyperechoic here as well with this fascial plane, but you can also see through it. So therefore, it's just a dense, connective tissue versus a bone. So again, when we look at the different muscle layers, we can see how we can very easily delineate, the trapezius muscles there, rhomboids there, and this would be the the erector spinae muscles as well. So, anyways, a very good image for us to basically review ultrasound anatomy. This is another image that's, again, darker. As you can see, I was true to my, I do like a darker image. We can see the gain is at 28 and the hertz is at 10. So that's a relatively, you can go up higher to 12. But again, this is a very shallow block. You can look at our target site is at 2 centimeters. And so the gain is appropriate. And it's a little darker and the frequency is appropriate for this type depth. Again, you can see the needles coming in here and these nice little markings. Remember in part 1 when I described that sometimes they put little notches on the needle that's going to reflect back the ultrasound to the ultrasound, and they come back hyperechoic. And this is exactly that. And that signifies that basically that's the tip of the needle. And that lets us know because basically you're going to see the ultrasound, if it transects the needle, like for example, right here, it's going to show up. You could be misled that that would be in fact the tip, but it's not. It's just that's where the ultrasound probe was placed, and then those sound waves crossed at that level. It can be a little misleading, so they several companies have put these little notches on there to kind of help us decide what the tip, where exactly is the tip of the needle. You can see here again we have subcutaneous fat. We see a nice hyperechoic plane here. This signifies the top of the pectoralis muscle, the bottom of the pectoralis muscle, top of the pectoralis minor, and the bottom of the pectoralis minor. And the serratus anterior has a nice, more of a hyperechoic. This would be considered more hypoechoic area. You see our needle coming in, and as I'm injecting local anesthetic, the tip of the needle came in contact with the rib. And you can see another hyperechoic structure here, which is the pleura. Obviously important to avoid that. It's also very important to note it. So when I go in to do one of these blocks, I really survey the area. And I do this with all of the blocks that we do. I don't just look for a nerve or just look for a rib and just go for it. I'm really more interested in kind of surveying all the anatomy just to make sure I can fill in this anatomical puzzle to make sure what I'm looking at is in fact what I think it is. And once the puzzle's filled in, then we can safely and appropriately perform these blocks. So as the needle came in contact with the rib, as you can see there, we injected local anesthetic and basically start filling up this space. And we can see how this nice line that I'm not drawing very well is starting to fill up with this dark substance. So it's fluid. It's a local anesthetic. And that's absorbing the ultrasound waves and basically coming back as anechoic. And that's excellent. That means that that injection is not going intravascularly. It doesn't mean that you won't have intravascular absorption. That's another issue, but you're not injecting directly in a vein. And so if you had a little air in your syringe, it's going to look like little stars. It's going to be kind of like lightning in the area. And that is not desired, but certainly you will see some of that if there's a little bit of air in there. But in this case, we de-aired everything, which I highly recommend because it's going to really distort the ultrasound image because it's not going to be absorbed. It's going to deflect it right back or echo it. And it's you're just going to see a white bunch of starry nights, if you will, there, a bunch of stars. So you can see that this muscle, the pectoralis minor, is starting to separate from the serratus anterior, and that's all local anesthetic. And so that's good utility of an ultrasound, avoiding vascular structures, avoiding the pleura, as we can see here. And without this, could you palpate the rib and come in contact and inject? Yeah, I mean, sure you could. But, seeing is believing, that you are in fact, if it was that easy, that we could always palpate the rib really reliably, and we encountered that rib or bony prominence, pretty easily, then I could see that. But the problem is, what if we're right here and we're like, well, let's adjust a little bit. We go into here, and then we basically just gave them a pneumothorax. So the ultrasound image is appreciated in this scenario to verify exactly where is the needle tip, and especially if things aren't going great, it definitely is advantageous or beneficial for us to do that. So, all right, so let's move on to the next image. Again, this is interscalene approach to the brachial plexus. And ultrasound, when I used to do these via nerve stimulation technique, we would palpate the interscalene groove, and we would go towards the transverse process. We could actually palpate it, and then we would elicit nerve stimulation when our needle encountered, this area. We were unsure if we were here, there, I just elicited nerve stimulation. Versus with the ultrasound guided technique, again, you can kind of survey the anatomy, see where the external jugular is going to be up in this area. It's a little compressed now. We can see the sternocleidomastoid muscle, and where the tip is, we look down and we see the brachial plexus. And so, we could think this is C5, 6, and 7, if you will. And we notice that this area is really dark, and it doesn't have, above the clavicle, we do not have a well-developed epineurium and perineurium. So you're not going to have that honeycomb feature. While we do have a very dense covering, a fascial plane here, certainly that's going to result in a hyperechoic image in that area. But it's going to be anechoic here, here, and here. We could think of that as a blood vessel. And again, by verifying, if you want to put on Doppler, color flow, just to check and make sure that that's totally appropriate. But again, seeing them in this fashion between the anterior scalene and the middle scalene gives us some reliable certainty that this is the brachial plexus. And again, before we would do our needle approach, going through the trapezius into the middle scalene and kind of approaching it at this trajectory, we could avoid any structures that we wanted to here. We could go down and look and make sure that it looks, like a supraclavicular approach, where we look at divisions and then the trunks of the brachial plexus, and then kind of slide the probe up cephalad in the neck, and then we'd start seeing this image. And that all gives us verification that we are in fact looking at the brachial plexus and at the level that we have desired to approach the brachial plexus. Okay, this is the paravertebral block. This is a nice image of that. And again, it's just highlighting the benefits of ultrasound, and that we can appreciate the fascial planes. They're hyperechoic. This is more hypoechoic. Again, another fascial plane. We can see the transverse process, and it's kind of squared off here. We have nothing underneath that because it's not an X-ray. That comes back anechoic. But then we can really see this line right here that's hyperechoic. And then also this other one with the red arrow by it. That's the costotransverse ligament. And this would be the pleura. So you can see how ultrasound has very much revolutionized the paravertebral business, because, when you place your needle and your trajectory is like such, and you have to puncture through the costotransverse ligament, but you don't want to puncture the pleura. We inject local anesthetic all in this area, and you can see how the incidence of pneumothorax has been decreased related to just accuracy of placing the needle. So we're not here to discuss that particular block in detail, but it does really highlight one. You can see the bone, you can see these fascial planes, you can see another hypoechoic structure at the bottom. It's going to slide back and forth. That means the person's breathing and they don't have a pneumothorax. And so that lets us know that the sliding, that things are going well. And we can also see the anatomical area that is desired to puncture with our needle and deposit local anesthetic. Okay, so again, another image of the interscaling approach. You can see our needle very well here as well. And that's the usual trajectory that I use for this particular block. And again, you can see the needle all through this area, and look at the bevel right there. And so this is a really good image to really highlight what sometimes can happen is that you can see that we're actually tenting that fascial plane to the middle scalene. I haven't punctured it yet. And could you stimulate at that particular juncture? Yes, you could. Because I'm really stretching that fascia really well, and it's going to come in contact with this nerve and it's going to stimulate. The difference would be is that the stimulation would go away. It's, you know, like let's say we stimulate at 1.0, but it's going to go away at the threshold would be at like 0.75. So we wouldn't be able to stimulate motor response below that, because we're really not in contact with the brachial plexus. We're just super close. And this is where ultrasound does have an advantage because you can actually see the anatomy that you're going for. And when I see it stretch like this, I just put steady pressure, and I just kind of put some pressure on the syringe as well, because it's a very dense structure. And then when we pop through there, we're able to inject and kind of push the plexus out of the way, a little bit safer modality. Again, safety first, you know, above all, do no harm. And we want to, this really demonstrates and highlights the advantage ultrasound does have over stimulation technique and certainly palpation technique, or, you know, eliciting paresthesia. So again, you can see that the frequency with this image is at 13. So it's a shallow image. We're, you know, less than 2 centimeters. Really the target that we'd like to, you know, contact the brachial plexus is less than 1 centimeter. So it's appropriate to have high frequency. Again, this is just my preference. The gain is at 28. So, you know, don't judge me too hard on that. You're like, this image is terrible. It's too dark. I hear it all the time. I do a lot of consultant work for various, you know, regional anesthesia companies. And when I go to various hospitals in the US, a lot of people criticize, like, you know, the image is too dark. You can lighten it up with the gain if you want. But I think, one, we can appreciate all the anatomical area, and we can see our needle just fine with that type of gain. But again, each to their own preference with that. All right. All right, so nerve stimulator. So we talked about ultrasound a lot, and now we're going to talk about the nerve stimulator. Electrical stimulation to locate the peripheral nerve utilizes low intensity, less than 5 MA, and I would say really 1 MA for superficial blocks and maybe 1.5 for deep blocks. And again, that type of electrical stimulation is going to let us know that we're getting closer to the nerve. And then once we get really good motor stimulation, we can dial down to let us know how close we are to the nerve, make sure that we're not in the nerve. And the duration of stimulus is hertz. That's the repetitive rate, you know, 1 to 2 per second. That seems to be appropriate. You can dial it up. Sometimes you get a faster response in that scenario. But again, if you're moving the needle in a very deliberate but cautious manner, 1 to 2 hertz is fine. Requires insulated needle. And that's the big part, is that you just want to stimulate the tip. We want to know if the tip is in contact with the nerve, in that it gives us an idea of a more appropriate placement of the needle. So the target is place the needle tip close to the nerve, but not within it. And so we want to monitor for the expected motor response. And that's key. If you think you see the radial nerve and you're seeking, that's the target, and you stimulate and you want to see a radial nerve response. And my 3 students are going to describe that with you guys on their presentations, but I really want to make sure that we all agree to this, that if you're going to do a nerve stimulator technique, we have to use an insulated needle. We have to think about what we're actually stimulating and to make sure that that motor response correlates to what you thought it should be. If it's not, then you've encountered a different part of the plexus or a different nerve. And that would not be, that was not the desired motor response. So therefore, we'd have to redirect. So once the desired motor response, you dial down the stimulation. So again, we're at 1.0 and we dial down, 0.7, 0.6, 0.5. If we're less than 0.5, the needle tip is probably in contact, misspelled, with the nerve or intraneural. And so if we get below 0.2, for example, MA, we would want to back the needle up a little bit because we're probably intraneural. The occurrence of a motor response at 0.5, at 0.1 milliseconds indicates the needle is nerve contact or intraneural placement. Again, that's why we dial down further to verify, is it, do we really think it's in the nerve intraneurally, which is not desired, could cause nerve damage. And so we want to make sure that if we get it at 0.5, we should prompt caution. The practitioner should stop advancing the needle. You may want to withdraw the needle a little bit and then inject some local anesthetic. Now, this idea of opening pressure we described, and that's the first time you inject. So if it's a lot of pressure, as you can see the manometer over here on the side, if you don't have one of those, you should judge the pressure with injection. And you also want to, that's the benefit of having the patient awake. If you're in fact intraneural and you go to inject, it's going to be tough to inject, more resistance, and the patient's going to probably have some pain on injection. Probably they will, and paresthesia. So that would prompt us to stop the injecting. And so again, this is basically just to determine if you're intraneural or you're just really close to the nerve. And once you inject, the motor stimulation will stop. Peripheral nerve stimulation should not be relied on if the patient is receiving muscle relaxants. That's key. So if you're going to do it under general anesthesia and they receive muscle relaxants, you can't rely on that. But in the presence of an epidural or a spinal, you can rely on it. It does not negatively affect the reliability of a peripheral nerve stimulation. And so let's say you do a spinal anesthetic for like a terrible lower extremity fracture or amputation or so forth, and you want to offer post-operative pain relief to that individual prior to the spinal wearing off, you could in fact still use peripheral nerve stimulation and, maybe do a femoral block, do a sciatic type block, and still be able to elicit motor stimulation. But if you're going to look for nerves and stimulation and they're kind of in the same area, a good example of that's like an axillary nerve block or interscalene approach, where you want to kind of, you really want to get more local in different areas, especially with the axillary. Just because you elicit, stimulation, motor stimulation from the radial nerve, you inject, and now you're looking for the ulnar. I wouldn't necessarily think that's going to happen very reliably. So basically you get to find the nerve, and the fact that you're injecting to go and find another one, it's going to be kind of iffy because you could get some effects of the local anesthetic that kind of spread over there, and that could cause more problems than maybe a benefit. So important equipment setup and tips from the NYSORA website is that you should use only a nerve stimulator specifically manufactured for nerve blocks. And we're going to bring 2 nerve stimulators with us for our conference in Cameroon in December. So we'll kind of show you how to work those. use insulated nerve stimulation needles, and we went over that as far as the the different needles, and we're going to discuss those in detail as well. Use high quality skin electrodes with low impedance. So some of the, if they're not in good shape, they may have too high of impedance and resistance, and really not stimulate very well for us. Before starting the procedure, make sure it properly functions, that the stimulator is working, all the cables are good. And during the procedure, you should check frequently to assure that the current is being delivered and the leads disconnect has not occurred. And again, most of the stimulators are going to be when you complete the circuit by touching or piercing the patient's skin with the insulated needle, and you have an electrode on, it's connected to the stimulator. It's going to go from a red light and a change in pitch and color. So it'll turn green, and you notice a little difference in the pitch, that it sounds different, the little click sound. That kind of alerts us that we in fact have completed the circuit and everything's properly functioning. The design of the connectors, they're normally pretty good. They're kind of hard to connect, so they kind of keep them together. But stuff happens. And so make sure that the correct nerve stimulation needle to the nerve stimulator, it should be turned on. I mean, I've been doing this for 22 years. I can tell you, I've seen some amazing stuff. People, I can't get this nerve, I can't find it. And especially during the stimulation technique days, and the stimulator was on pause, or it wasn't even on. And it's like, okay, let's start with step one. Let's turn the thing on and make sure we can stimulate appropriately. So again, for superficial blocks, it's okay to select 1.0 MA for your starting. Be prepared to dial down. For deep blocks, you can start at 1.5 MA. And again, select between 0.1 and 0.3 milliseconds of current duration. For the most purposes, that should be fine to do that. Now, the review the difference between, if you have an insulated needle that basically has the bevel covered as well, you're just stimulating the tip. And so this is nice, where basically we're going to encounter the nerve, and we only have to worry about, like, it's all spraying in this area. And so we know that we're going in the correct trajectory towards the nerve. And then, as we're using higher stimulation, for example, high stimulus, we get a motor response. We start dialing down, and now we're trying to decide, okay, how far away are we from the nerve? In this particular scenario, we have stimulation, and it's really good motor response. You start dialing down, and you still, you're at 0.4, 0.5, you're getting good motor twitch. And then it goes thresholds met at let's say 0.3, 0.4, which means you're probably in contact with the nerve, but you haven't entered the nerve. And that's really good. So you definitely have now the tip, and you're basically in contact with the nerve, or very close to it, but you're not in the nerve. And then at that point, we can inject local anesthetic, frequent aspirations, at 5 ml intervals. And, again, you have a higher energy as you're approaching the nerve. And as you get a really good response, you decrease the energy, and the stimulus matches. So the stimulus and the motor response match, you lowering the MA, which means it'll be a weaker stimulation. And so that's all appropriate, and that's all what we predict to happen. Okay, so at this point, I'm gonna. All right, so when so you connect the needle to the nerve stimulator, we advance the needle towards the nerve as we showed on the previous image, and needle adequately placed as seen on ultrasound. If you have no twitch, and then again, this is comparing, nerve stimulator, or pairing nerve stimulation with ultrasound. So needle placement by ultrasound, you have uncertain or poor images. They recommend at this point, turning on the stimulator and see if you have a twitch. If you do have a twitch, needle adequately placed as seen on ultrasound, twitch present, reposition the needle to ensure no twitch. at less than 0.5. Again, they're trying to establish that they're not in the nerve, they're just really close to the nerve. And again, if you get kind of lost on the ultrasound, you can increase the MA to see and adjust your needle placement to see if you can get closer to another structure that could give you stimulation. So ultrasound paired with stimulation is a very good technique. So if you're used to doing stimulation and you want to incorporate ultrasound, it's okay to use both techniques. Again, making sure that you make that your ultrasound anatomy looks good and that your stimulator's properly functioning. If you could pair those two together, you could enhance your ability to place these blocks. This slide is just really highlighting the fact that insulated needles are necessary. Just because an uncoated needle, as you can see in this image, is really going to scatter your stimulation all throughout the needle, and it's not going to be able to reliably tell you, as you're injecting here, but yet the nerve is maybe here. You're not as close. Versus if the bevel is exposed, you're going to be, fanning like this area, and so we're in some idea, you kind of narrowed, you kind of cut out all of this part of that, and you're able to stimulate in this fashion and see if we're encountering the nerve, and basically help us have more accurate placement of the needle. Again, if you completely coat it, that's where the bevel is not being stimulated, just the tip. That's where we can, really verify that this tip is in contact with the nerve. And when let's say you're at 1.0 MA and you start dialing down, you get a good response, that with some degree of certainty that the nerve would be, more in this area. So 15-degree needle versus a 30-degree as far as, bluntness, if you will, and demonstrate that gives us some security that we're not going to or decrease the incidence of us actually piercing a nerve because our needle isn't quite as sharp. This image is again highlighting the various needle types, bevels, and you can see the insulation kind of stops here and here. So we're gonna, this is gonna be a stimulation all through this area. It's still pretty good. You can see the short B bevel needle versus the longer one. More likely to pierce a nerve, if you will. A little less likely. And TUI is my all-time favorite, is because while it's a little blunt going through certain fascial planes, those of you used to doing epidurals, we do have some reliability that it's going to kind of push stuff out of the way. Not vessels necessarily, but I do like that technique. Then when we place a catheter, the catheter comes out in that fashion. So I do a lot of continuous plexus anesthesia. I would say, I probably daily place, anywhere from 8 to 10 continuous peripheral nerve catheters a day. So I'm more, used to or accustomed to the TUI tip needle, but I've placed, we do single injection, normally paired with our continuous plexus anesthetics as well. Okay, so this is part 2 is completed. Part 3 will be next, and this is where we'll basically pick up with axillary and femoral and popliteal. I'll describe those again. Not to steal the students' presentations, they're going to do detailed lectures on that, but I at least want to introduce those topics as well. And thank you again. I'm looking forward to seeing you guys in December, and I'll see you soon for part 3.